welcome. So today we're gonna talk a little bit about certain things that are currently ongoing, such as COVID-19, and then we're gonna talk about how when patients present, especially in the ICU, or in general, sorry, or in general when you want to intubate them and put them on a ventilator, some of the stuff that we do in a hospital just to try to help them maintain hemodynamically or tolerate this ventilation. So I know this is, I'm gonna try to paint the picture the best way possible to so that you guys, so we'll look at it like you're in ICU, you're coming in, you're rotating, you're shadowing, and you see somebody from when they come in admitted to the ED, and then there's an emergency, and then they get upgraded to the ICU or something like that. So we try to keep that frame of mind while we're going through this presentation. So with that being said, should I continue moving forward, or you guys have something to say?
You're good.
Okay. All right, let's see. Everybody can see the screen?
Yes.
Yes.
Okay, let's see. All right. And are you seeing the slideshow, or are you seeing everything I'm seeing on my screen?
Seeing everything.
Wait, so you seeing a slideshow on one end, you seeing all this on the right
Yes.
side?
I think if you click the little top part that says use slideshow, it'll like full screen. Yeah. There you go.
Okay, perfect. All right. So the content that we're going to talk about shock, the types of shocks. We're going to talk about pressors. We're going to talk about sedation. We're going to talk about paralytics. These are important, right? There's different types of shocks, and there's different requirements for certain pressures that you may need. And a lot of different disease states can cause shock, right? If there's infection, they can get sepsis and they have septic shock. If it's direct to the hit to the heart, they get like a cardiogenic shock, et cetera, et cetera. So the management for different shock states are a little different. But the most important thing is that when you have a shock, you need to make sure hemodynamically that you're stable. So when these come into play, when you're trying to stabilize, that individual, that patient, shock is when your organs are not getting good perfusion, and basically it's like a diffuse thing, So let's talk about the different types of shocks. All right, so when we're talking about shock, this is a basic formula we use, right? You have mean arterial pressure, which is MAP, equals cardiac output times stroke volume. So cardiac times systemic vascular resistance, SVR, and then cardiac output is heart rate times stroke volume. So anything that affects any of this equation, right, the cardiac output or the resistance, will change the mean arterial pressure. So for most people or everyone, the normal mean arterial pressure is about 60 to 65, right? And you need to maintain such a mean arterial pressure because your brain senses this level and says, you know what, we're gonna do this auto regulation. If it's low, then what you worry about is your brain getting good perfusion, because auto regulation happens when your brain senses the mean arterial pressure is changed. It doesn't know whether it will say vasoconstriction. So you constrict it in the brain, the vessels that supply blood, but the problem with that is you constrict it to get more supply, but brain is such a closed and difficult area where the more you constrict distally, the less they get a blood supply. So you end up having anoxic or anoxic brain injury, because the auto regulation, that's what your brain's supposed to. So by you keeping the mean arterial pressure level at a certain parameter, the perfusion in brain is not compromised, because the body sometimes does something that it's supposed to do, but if he overdoes it, then it compromises, because anatomically it's not supposed to tolerate such a state like that. So that's why it's important to, if you ever go in the ICU and you see somebody in the pressors, they set a parameter and say keep the MAP at 60. So when you're doing these pressors, if you overdo, so pressors are going to affect a lot of different things, right? They're going to affect the resistance. It's going to make the resistance higher, right? Because it basically constricts. When pressors constrict the arterial supply, right? And then cardiac output, some pressors trigger this cardiac heart rate, right? And depending on what state you're in, if you're in a period of shock is going to affect the stroke volume. I mean, cardiogenic shock is going to affect the stroke volume because it's happening at the heart. If it's sepsis, for example, that's a septic shock. That's more on the periphery. When the patient has bacteremia, where the infection is in your blood, they release toxins, which causes vasodilation, right? And that can affect the resistance. So resistance will go down, and in turn, your cardiac output tries to compensate for that, but to no avail, because you need some type of resistance for the cardiac output itself to have enough strength. So I hope this is making sense. So let's move forward. So what is shock? So shock is reduced oxygen delivery, and it can also be increased oxygen consumption, essentially. And then to classify shock, you have hypovolemic shock, meaning that you're bleeding out, right? So the problem in this case is that you're bleeding out. You may have like a wound, a trauma, and then you're bleeding. You're not keeping blood in a vascular space. You're losing a lot. So that's when you say hypovolemic shock. Cardiogenic shock is a direct onslaught on the heart. It could be after MI or something like that, heart attack, or you got, infectious cause that causes a cardiogenic, where your heart is not pumping sufficiently. So you're in a state of shock. It could be obstructive shock. It could be something called pneumothorax that becomes a tension pneumothorax, and you basically end up having mediastinal tension that causes pressure in that system, and then you have a shift, midline shift, that compresses your veins supplying your right heart and your aorta. So hemodynamically, you're gonna have a low blood pressure, but you're gonna be under a lot of tension because it's an obstruction. So that's what you call it, obstructive shock. Then you have the distributive shock, as we spoke before. The distributive shock is generally from an infectious origin, and the patient gets into septic shock, right? And because these organisms have these toxins which they release. So there are a lot of bacteria that are prone to causing septic shock. Or in general, sometimes what happens, especially let's talk about COVID in this regard, distributive shock. Some people go into shock because their mounting inflammatory response to this virus, where your immune system overfires, per se. Let's keep it short and say it's called overfiring. The better medical term is cytokine storm. So I don't know if you guys know what cytokines are. In the immune system, whenever your body's fighting At times, you call upon cytokines to come help communicate what is required. And sometimes in an infectious state, you overproduce cytokines, which your body your body releases inflammatory messengers and things like that. And, you could be in a state where the inflammatory response is so high that it takes time to come down from that inflammatory response. So you end up developing distributive shock and needing assistance. Okay, so clinical features of shock. So you have hypotension, tachycardia, oliguria, meaning that you're not making any urine. And we'll explain further how, all these things manifest. Abnormal mental status, tachypnea, you feel cool, clammy, cyanotic skin, metabolic acidosis, hyperlactatemia, right? So hypotension obviously means, your blood pressure is low as a result. Because as we spoke about, what is this?
You can just X out of that at the top or minimize the screen.
Oh, you typed this question?
Yes.
Oh, this is quick. Oh, this is awesome. I love it. This is amazing. All right, let's see.
But you can either just minimize it and keep going. It won't affect anything.
Okay, good. Let me ask. This is amazing. So you guys are really, at a fast rate. This is awesome. So tachycardia is obviously your heart rate is fast, above 100. Oliguria is when you're not making urine. Abnormal mental status is obviously you're out of it. Tachypnea, breathing fast. So elevated respiration rate when you feel cool, clammy, and cyanotic. So oxygen is not getting to the skin as it would, because in this state, all the peripheral organs start to lack proper oxygen. The more distal organs start to lack proper oxygen, so you're not getting the oxygen like that. Basically, all the blood flow is rerouted to major organs that deserve it at that state. So you're gonna have cool, clammy. So you're not getting the temperature cool. So your blood itself kind of like is a temperature regulator for you. So you feel cool, calm, and clammy because the outside world is cooler than the inside of the body. So your blood flow kind of puts you at a good normal temperature, and then when you're in shock, you're gonna be cool. Metabolic acidosis, we'll go into how shock causes this, because obviously organs begin to not get good oxygenation. So when you don't get oxygen, it's just, if you guys remember the glycolysis and the Krebs cycle and all of that stuff, if you don't have oxygen, then you can't use sugar. You can't go through that, and you can't make ATP. So when you don't have that, you go into anaerobic metabolism, and a lot of organs do this. So let's see which type of shock is caused by inability for the heart to pump sufficient blood that it needs. Wonderful. So 72% got this right. Awesome. Good. People are flowing. So metabolic acidosis happens as a result. You make a lot of lactic acid. It builds up in the body. You use up a lot of your bicarb, as I was telling you three before. But we'll get in detail about this. Let's see. Every time I click forward, it just overdoes it. Like relax. All right. Let's for our first case. All right. I know you guys have your own questions about this. This stuff has questions as well. Let's see. All right, so first case, we have a 70-year-old male with a past medical history of hypertension, diabetes mellitus, dyslipidemia, presents with fever, shortness of breath, and cough for 2 days. All right. So initial vital signs for this patient is 90/60. The blood pressure is 90/60. Temperature is 101.2. Heart rate is 109. Respiration rate is 22. You do some labs, and it's significant for WBC, which is white blood cells, of 19. The arterial blood gas shows a pH of 7.32 with a CO2 of 33. Has a bicarb of 19. Lactic acid is 4.1. The chest x-ray was done. It shows a left lower lobe opacity. Cultures are drawn, and broad spectrum antibiotics are initiated. On physical exam, he is alert, but his extremities are cold and clammy. What is the initial step in resuscitation? All right, so let me just, this is a case that is a little advanced, for you guys, but let me kind of, break this down so that we can all benefit on the same page. So this is a 70-year-old patient with underlying history of hypertension, diabetes, diabetes mellitus, and dyslipidemia. So, so this patient is already like, they have this underlying stuff that puts them at risk a lot, right? And this person doesn't have to have a past medical history of this, and then say to have such a presentation. But oftentimes, this is what you truly see in hospital: elderly, older patients, or people who have like diseases such as diabetes. Essentially, when you develop diabetes, you become slightly immunocompromised, because it's like a state where your immune system is always in flare, and so you're a little bit more prone to things. So this patient, long story short, has pneumonia, right? So when we talk about left lower lobe opacity, something is collected in the X-ray. When you're looking at the X-ray, something is collected. And typically it's like a whiteout in the X-ray. And at the lowest lobe, there's a collection there. So that's what they're able to see in the X-ray. They drew some cultures, and what you do in a hospital setting is that when you're treating like pneumonia and you're suspicious of something, you start off with a broad spectrum. So broad spectrum antibiotics is going to cover a wide range of bugs, right? Wide range of bugs before you know it, the actual bug that you treated. So you're doing all these cultures, whether it's a sputum culture or blood culture and stuff like that, to figure out what type of bacteria is causing this incident. So, but before that, you start on a broad spectrum just to cover all the gram-negative and the gram-positive. That's what we do in the hospital. You start like that, and then keep the patient on that. But you don't want them to be on a broad spectrum for too long, because organisms bacteria can become resistant to it. But when you narrow down the target, for sure there's specific antibiotics for this bacteria that you can get to that point. So this is the initial intake when a patient presents. So right now, this patient is hypotensive at 90/60. So hypotension is present. This patient has fever at 101.2, and heart rate, the tachypnea. Tachycardic is that's their tachycardia. They have 109 heart rate, and they have tachypnea, respiratory rate of 22. So something is going on. First of all, you say this patient is hypotensive, they must be in shock, right? So that's number one. This patient is in shock. You look at the ABG, and the ABG, you see that they're metabolic acidosis state. Why I say that is because, first of all, the pH is 7.2. Normal pH is like 7.4. So this pH is 7.32. So they're acidosis state. And bicarb itself, the normal level of bicarb, which is this, is 24. So there's a drop in bicarb. So the base is losing. So essentially, this is acidosis, and also they gave us a lactic acid here, showing that the lactic acid is elevated. Just like I was telling you guys, when you're in a state of shock, you're gonna make lactic acid. Organs are gonna make lactic acid. So you can pull from the blood and see what's the lactic acid level. That means there's some anaerobic respiration, anaerobic process is going on, right? So in this setting, the question is, what is the initial step in resuscitate this patient? So what we do is what we do in a hospital setting. When somebody is hypotensive, the quickest thing you can do is to give fluid, right? You give fluid to basically, if you gotta realize it's a volume issue most cases. It's a volume issue most cases. So you give fluid and see how the patient responds. So I'm just gonna take you guys. All right, let's do a quick question. Which of these sets of fluids do you think you give?
Okay, so we're waiting. We're waiting in the chat.
Yeah.
People are saying B and C. Those are the two coming in.
People say B and C?
Yes, those are the two options that we're getting.
Okay. All right, so B and C, okay, that's not bad. These are not bad choices to consider. But the answer here will be C, right? C, because you just do a liter bolus of normal saline of LR. Because these are these when you give fluids, you don't want, so like right here, this is hypertonic saline, right? You want fluid that doesn't have any extra, constituents in it that's gonna drive a certain response. These are the general basic fluids that we give in the hospital setting: normal saline and lactate ringers. And you monitor patient response. And fluid resuscitation is a whole different lecture of its own, to know what type of fluids you give in certain infectious states or certain metabolic states that the patient may be in. If somebody's in diabetic ketoacidosis, or there's a certain protocol of fluids to give, right? That have certain things in it, because these fluids have to have a certain level of sodium, certain level of potassium, and stuff like that balances with your normal body level, so that it's not over providing you with stuff. So these have that. So you would give C, which is the liter bolus of normal saline, and see how the patient responds. Right? If a patient responds well or holds up, then okay, maybe it was due to dehydration or whatever the case may be. If they don't hold well for the time, you kind of resuscitate them, but you see it's not holding well, then at least you buy time a little bit for other stuff, to like the X-ray to come back, and for you to put in a couple lines and things like that, to make sure the patient is prepared for any advanced management. So we'll do a liter bolus of normal saline and lactic ringers, and we monitor the response. So that would be the answer. So the roles of intravenous fluids is, as I was mentioning, is recommended initially for hypotension. And then the question is how to give, how much fluid to give, and what kind of fluid to give. So these are the questions that in medicine that you now be asking yourself: what kind of fluid, right? So 30 milliliter per kg of intravenous crystalloid fluid. So you want to give a crystalloid fluid will be given within the first 3 hours. So what you do the math, right? You check the patient's weight with this, and then it tells you how much fluid to give that particular patient. So you want to give this within the first 3 hours of the patient coming in. So case continue. So once you've given this, right? So now you're monitoring the patient, and his vitals now, blood pressure is 80/40, heart rate is increased, temperature's up, respiration rate is up after 4 liters of normal saline. So this patient got 4 liters of normal saline, right? They got 4 liters. That's a lot already, and and there's no response. So the patient is still awake, alert, and oriented ×3. The patient is now oliguric, has not had a urine output. Extremities remain cold and clammy. So if you get fluid, you should be able to get good perfusion to your kidneys. You should be able to make urine. That's just kind of like, oh, so you say this person is not fluid, didn't respond well to the fluid that we gave. So definitely now needs something. So now the question is, what do you do next? It's now becoming a perfusion problem. Would you, if the fluid that you gave does not work, does it really make sense to start a maintenance fluid? What's the point of starting maintenance fluid if the initial fluid given, did not work? Is not going to work. Take the patient to cath lab. The patient is not hemodynamically stable for any advanced operation. So we will not be doing this. To change the antibiotic regimen. I don't think the antibiotics is what's really what we're thinking for right now, because the infection state, of course you want to fight it, but it's not what's going to change this patient's hemodynamic state. So the next thing we'll do, we have to now begin the pressor therapy, meaning that, so we're supplying fluids, but the problem is the resistance is not allowing for all that fluid in the vascular space to be delivered properly, right? It's a two-way street. It's a two-part thing. You have supply. Remember the mean arterial pressure, which we were talking about, is cardiac output, right? Times systemic vascular resistance. So cardiac output being heart rate times stroke volume. So, if we want to use that, if we want to use that equation that we spoke about earlier, this equation here, if we want to refer back to this equation right now, to I hope you guys could just write this down so I don't have to keep going back to this, or just capture this in your mind and make it easier to kind of bring up when I do. So in this case, this patient heart rate is 128, right? So the problem with a heart rate of 128, the stroke volume itself will go down, right? If you want to maintain a certain cardiac output, the stroke volume has to go down. So the higher the heart rate is, the less is being pumped out in every stroke of the heart. You know what I'm saying? That the heart goes through. So your heart rate has to be at a certain level so you can get an adequate stroke volume, right? So that things are being delivered, right? So when you're pumping fluids are ultimately getting pumped and going through the right side of the heart, so they can come out and get out, so you can have push. Fluid help push blood and stuff like that. So you get fluid, it helps push what's there, right? It gives you a push, so that you can have increase in flow, and then what you take in, you're able to extract some of the constituents of the blood. So that's why you basically give a push. You think about flushing something through a pipe, and it's like a little bit flow. You put like a flush of water. It's supposed to push all those things down and kind of like clear. So you think about it like this. But if there's a busted pipe, or all of that pressure that you're putting in is not really helping, because there's a leak per se, if you want to look at it like that. So basically, the blood vessels are a little flaccid because something is telling them not to give that force. So now we begin the pressure therapy, which allows us to do so. So that's what we do. Now you have to start pressors. You have to start the patient on some type of pressure, and most of the time, you wanna give these pressors through a central venous access. So in a hospital setting, sometimes when a patient is like this, now you have to give them a central line, meaning that when you look at your vascular tree, the big vessels, you want to feed it. You want the medications to be feeding, because each level of the vascular anatomy has a certain group of muscles. and these pressors act on these group of muscles. So if you give pressors very distally, right, and as soon as you give these pressors, your distal arterial supplies are going to vasoconstrict extremely, and with that, what that causes is like you lose circulation to the extremity. So having vasodilation and severe vasoconstriction is essentially the same thing, right? Because you're not getting blood flow in the distal limbs, so you can end up getting, necrosis, and vasoconstriction is a little bit more painful than vasodilation. Vasodilation is like a slower reduction of supply, but vasoconstriction can be very painful when it's happening fast, and your skin will just turn blue and all of that. So that's something to keep in mind if you're in a hospital setting trying to start a pressor. You wanna supply these pressors at a central venous unit. So typically we do the internal jugular access. We do a femoral vein access. So you can imagine once you go through the internal jugular, you're going straight to the superior vena cava, and then things like that happening at a central point. Okay, let's see. So now let's talk about vasopressors and inotropes, right? So as I was noting before, that pressors increase blood pressure by stimulating constriction of blood vessels. So they basically increase the vascular tone. So basically what I was telling you guys before is that, so you go from here to this, right? The radius is a little bit narrower, obviously it's going to cause more velocity and flow, right? And also you have inotropes. Inotropes alters force or energy of the muscular contractions. So positive inotropes increase myocardial contractility. So when you go back to that, so you see why you affect the mean arterial pressure, because contractility is basically going to help the cardiac output, and then the pressures is going to help the vascular resistance. Let me see. I got a new question. Stop sharing. Okay, let's see. What's up with shock? Okay, I see. So lost the poll. Nice. So I see you guys have another question. Oh, nice. All right, so that's what we have with vessels and inotropes. So now we have a couple pressures that we use in a hospital. We have norepinephrine, we have epinephrine, we have dopamine, we have phenylephrine, we have dobutamine, right? So basically, so there's these so you have alpha and beta receptors all through the body. Most peripheral have alpha 1 and beta 2, and then cardiac is, the receptors in the heart is beta 1. So norepinephrine is what we really use a lot, right? Because we're able to get both. We're able to get a peripheral support and we get a cardiac support. So you work in both. So it helps keep that mean arterial pressure. So this right here is gonna alter the resistance, the systemic vascular resistance, and this right here is gonna help the cardiac output, right? Because it is acting inotropically to the heart. And then see epinephrine, this beta 2 causes a little bit of vasodilation. It causes a little vasodilation. So it has almost the same strength as norepinephrine, but because of this, we don't want to tamper with this, right? And sometimes they all have their adverse effects. So the first line we typically use is norepinephrine. You call it levofed in a hospital. And then the next one that is pretty good is what all good is all situational, and we'll talk about when to use this. But I'm not gonna make this topic that advanced because you guys were not, kind of. I don't want to give you guys too much. I want to give a good understanding from where you guys are at this point. So these are the pressures, and we'll come back to specifics as we move forward. So let's talk about a little bit of receptors. So you have this neuron, synaptic cleft, you have adrenergic receptors, you have norepinephrine coming from the synaptic bulb and being released in the synaptic space. So they bind to their receptors. So every organ has receptors. These will, like the heart has beta 1, arterioles have beta 2, which causes vasodilation, as I said. Beta 1 is seen in the SA node, which causes chronotropy, basically increasing your contractility. You have beta 2 in the lungs, causing bronchodilation. You have alpha, peripheral vasoconstriction. So norepinephrine can bind to all of these for the most part, mainly beta 1 and alpha. So you're able to get the contractility, chronotropy, and the vasoconstriction. And that's basically what these neurotransmitters do. And so when we're giving pressors, we're giving them these transmitters to bind and basically act artificially to maintain a patient's hemodynamic state depending on what they're requiring. And obviously most of these have side effects. Some of these can cause arrhythmias, and there's some that you give when a patient is already having arrhythmia to avoid furthering the arrhythmia. So this one is norepinephrine. This is levofed, mainly alpha 1 and beta 1, as we spoke already. So they're potent vasoconstrictors. These are preferred in septic shock. So when a patient is septic shock, you can see why it's important. Septic shock causes systemic vascular resistance drop. So by you giving them a strong alpha 1, you're going to be able to up that resistance. And in the beta 1, you're able to support their cardiac output to an extent, but you titrate it accordingly, right? So you do this in titration. So you give a little bit and see how their response, and you titrate till you can have a MAP level of 65. You want to get to that point. So you don't want to give it to where the MAP is excessively high. You want to maintain it at a good 60. Typically in ICU, they say 60, but a good parameter is always 60. So next question. So you decide to begin levo on this patient. However, despite titrating levofed drip up, the patient's blood pressure remains 84/46, heart rate of 115, the temperature is still high, and respiration rate is 20. He is diaphoretic, extremities are cold and clammy, patient is still AO times 3. What would you do next? So, Lovenox is an anticoagulant, so that's not helpful here. Change the antibiotics regimen, that's not really going to help us here. Add vasopressin to target MAP greater than 65. I think this will make sense because we're still not achieving the goal that we want when the levofed was given. By calling the code blue, this patient is still awake, alert, and oriented. I don't think one should be calling the code blue, because they're still awake, oriented times 3. Just hemodynamic state that is failing, and this is severe septic shock. Severe shock still. So you need to hurry up and do something. So I think adding another vaso to target MAP of greater than 65 is what makes sense in this case. I hope you guys are following. All right, so this is vasopressin. So this is vaso. So vaso is another good. So whenever you already have like a pressure like Levofed, to support it, vaso is good because it augments other pressures. Because this one is just a pure vasoconstrictor, right? That's all it does. It doesn't do anything else for the towards the heart. It just vasoconstricts. It's just strictly peripheral support. So you add this to augment other pressures. So the next case, 70-year-old male with history of diabetes mellitus, hypertension, dyslipidemia, presents to the ED with confusion due to UTI. All right. Despite aggressive fluid resuscitation, his blood pressure remains 70/40. Heart rate is 130. Sinus rhythm. So the heart rate is 130. The patient is in sinus rhythm. I will once I finish reading this question, I will break it down why it's important to note some of the stuff that's mentioned here. Respiration rate is 20. Temperature is 101.9. He's on adequate antibiotic therapy, but they ask if you want to add pressure therapy. What would be good choice? So they already told us that this patient has a UTI, obviously in septic shock, due to the infection. Why it's important when your heart rate is very high, like 130, right? The problem we face in medicine is like with a high heart rate like that, you want to understand what is causing the heart rate to be like. In this particular case, we know that this patient is hemodynamically is hypotensive, right? But we also want to know what is causing the heart rate like this. Is it in synchrony or out of synchrony? So oftentimes with a heart rate that is elevated, you get an EKG. So EKG now gives you a strip reading of the heart rate. And you're able to see that, okay, this is normal sinus rhythm. This is not atrial fibrillation. This is not irregular heart things going on. Because now what you give is key. The type of pressure you give is key. So now we have these options. And this, like I said, this is very advanced, but I was going to let you know the gist of this is to know that this patient is sinus rhythm. And depending on their states, you have to be careful of the type of pressure you give them. And the safest pressure to give in this particular state, especially when a patient is tachycardic and doesn't have any irregular beats, phenylephrine drip, GTT means drip, is the best thing to start. The vasopressin could further, strictly vasopressin could further cause increase in the tachycardia. And this is an augmenter, right? If you want to add pressure therapy, like phenylephrine will be really good in this particular case, as opposed to the vasopressor. Because we said before that you want to add vasopressor. We said before that you want to add vasopressor in addition to another pressure, because this equation is asking to add additional pressure therapy. So in this particular case, phenylephrine versus vasopressor, the question would be, what do you get? With the phenylephrine, this is what you're going to get. Vasopressin is strictly just a arterial pressure. But with the phenylephrine, you get just this alpha peripheral push. And with the vasopressin, like we discussed, is just strictly is a pure vasoconstrictor as well. But it is good for augmenting other medication that you've already given. So in this case, you give phenylephrine, and the next slide is telling us that phenylephrine, aka phenyl, aka neo, we call it neo, is a pure alpha adrenergic agonist. is a vasoconstrictor with minimal inotropy or chronotropy. So it doesn't touch the heart like that. It just touches peripherally. And this is reserved when patients have tachyarrhythmia, right? So basically, in this particular case, this patient already has a heart rate of 130, but it has a tachyarrhythmia, right? It's just in high tachy states, you want to give phenylephrine, right? And that's one of the times when that will work very well to add that neo, because other pressures would further worsen that tachyarrhythmic state. But phenylephrine is reserved when your patient is already in that state. So now you see why you give, because they're both going to do the same thing that you want them to do. But this one is better because of the state, the heart rate already. So it's very tricky. It's very important. There's a lot of thinking going on in ICU. You have to know everything, right? Because you can't start giving something because of what one side looks like. You have to look at the whole picture to know what is going to work best for a patient. All right. So next pressor is dobutamine. Dobutamine is strictly for is a strong beta 1. It's very good at cardiogenic shock. So with cardiogenic shock, you have low cardiac output, and adequate blood pressure. So the cardiogenic shock is a problem with getting adequate stroke volume. So in every stroke that the heart takes, the volume being pushed out is very low, although the heart rate is up, but the cardiac output is low. Based on that equation, that cardiac output is heart rate times stroke volume. So it's not a systemic vascular resistance issue. You're going to see resistance high, but the cardiac output is going to be so low that the MAP level is obviously going to be low. So you're not getting good supply. And in this particular case, you're not going to start the patient on levofed because the blood pressure is adequate. In this particular case, you would give dobutamine, right? And at times, if you want to add something to the dobutamine, you could do a vasopressor if you need extra support with the blood pressure. But in this case, the patient is going to have adequate blood pressure, but the cardiac output is going to be very low. They're going to be in cardiogenic shock. And the cardiogenic shock could be taking time. The shock would develop like if somebody has cardiac tamponade, which is around the cardiac sac, you begin to have like fluid, which pushes on the heart itself, and the expansion of the heart, the suppleness of the heart, loses its suppleness. So as it's pushing against fluid. So it slowly equalizes all the pressures in all the chambers. So the heart is a closed system, and if something happens that causes irregular rhythm, you can get a shock. If something causes equalizing all the pressures of the heart, it can cause shock because you need different pressure to drive flow. So if something causes equalizing of pressures and everything because of something on the outside, such as cardiac tamponade, then you're going to be in cardiogenic shock till you do something, pericardiocentesis, which is when you go inside the pericardium and take the fluid out. It relieves that pressure. So in medicine, you always ask yourself, what is causing this particular thing? We know hemodynamically the patient is showing a clinical picture, but what is the actual issue? And that's how we go back and try to repair that and fix. So obviously, these artificial medicine that we're given, because at this point, what is very important is the MAP, because like I said, you don't want to have anything happen to you neurologically, right? We always think about how do we save the brain, because these autoregulators are going to come into play if this is. So we're thinking, how do you save this patient from having anoxic injury? Because obviously, if your brain dies, what's the point of every other organ? You can save the body, but if the brain is not really functioning, then what's the point? You're not really you're not living, to be honest. So we talked about dopamine. So dopamine acts to increase the renal mesenteric blood flow. So in the kidneys have a dopamine 1 receptor, and it also has some beta, depending on the level. You have a beta 1 and alpha 1. So dopamine is also another good at a very, very low dose, it acts on the kidney. At a very medium dose, it acts on the beta 1 receptors, and alpha, it helps constriction. So I'm gonna start to kind of go a little fast with these pressures, but you guys get the gist now that when it comes to pressure management, the state of a patient is very, very important. And there's a list of things that try in the ICU settings to make sure this patient is hemodynamically stable. And then we have epinephrine, which is a very potent beta 1, beta 2, and alpha 1. It helps increase cardiac output. It helps you give it for increased cardiac output and decrease systemic vascular resistance. But the thing about the beta 1 receptors, they can provoke dysrhythmia. So you have to be very careful giving this because it is a very potent beta 1. So if a patient is already at risk of arrhythmia, you don't want to give him epinephrine. The only time you do epinephrine because of its strength is when the patient is really, like, this is like last resort pressure that you're trying to give. And there's also used in ACLS. Of course, it's used to treat anaphylaxis. So this is the drug of choice for hemodynamic support in anaphylactic shock. So if you're in an anaphylactic shock, epinephrine is a good one. Like if you eat something and you're having like allergic reaction to it, which is self-caused shock, you give epinephrine. Also use it for hemodynamic support in early post-operative period following cardiopulmonary bypass surgery. Epinephrine infusions are not preceded by a loading dose, the initial infusion. So this one is irrelevant information for you guys right now. All right, and then there's another one, Milirone. This is a non-adrenergic drug with inotropic and vasodilatory actions. This inhibits breakdown of both CAMP and CGMP by PDE2 enzyme, and this one is used in cardiogenic shock. So the two medications. So what two medications are good? This should be the next question. What two medications are good for cardiogenic shock that we just talked about?
Someone said Dobutamine.
Huh?
Dobutamine.
Yeah, Dobutamine and Milrinone are, when patients in cardiogenic shock, these two medications are very, very good. So summary of pressures. In hyperdynamic septic shock, norepinephrine is first-line agent, vasopressin as a second-line agent to reduce need for other pressures. In cardiogenic shock, once again, norepinephrine is preferred initial agent. After establishing adequate perfusion, dobutamine or milrinone can be added. In anaphylactic shock, the first-line agent is epinephrine, followed by vasopressin as a second agent. Epinephrine is the first-line agent in hypotension after cabbage. In both neurogenic shock and anesthesia-induced hypotension, neosynephrine is the first line. So neosynephrine is phenylephrine is the first-line agent. So these are a summary. These are a summary of the pressures. But I hope you guys understand that the reasons why pressures are being used, and knowing the state of a patient, knowing the shock state, and it's very, very important. So once you classify the shock state, then you can say, oh, we need to use this. But the good thing is that norepinephrine is always the first line, and then vasopressin is a second line agent. So it'd be nice in the future, one day you do an ICU rotation and you remember this lecture that you're currently receiving, and then you ask some of these questions, you know, and then I talk about shock. Everybody talks about shock. Shock is a very important concept in medicine, you know, and if you're interested in surgery, you need to know shock very well. Stages of shock is another thing too, that one has to know, and things like that. So shock is a very huge part of medicine, and then this is life and death. So next topic we're going to talk about is sedation. So sedating a patient is very important. You sedate a patient in many ways so that sometimes you want to ease them out. Because sometimes somebody being alert, there's this sympathetic response, right? This is sympathetic response. They're in fight or flight mode, and sometimes it can worsen to shock state. And when you need to intubate these people, you also need to sedate them, right? So to slow them down to tolerate the oxygen, because there's two things. You want oxygen delivery, because shock is essentially fast consumption of oxygen or not enough delivery of oxygen. You know, that's essentially what shock is. So next part, you want to intubate a patient in this particular state. When a patient is hemodynamically unstable, you have to either give them pressure. They're required to be intubated. So anesthesia promptly arrives and your patient is now successfully intubated. His MAP is now 80, heart rate is 130. The breathing is synchronously with the vent and appears to be reaching for the tube. What do you want to do? So basically now you've already intubated a patient. The patient is reaching for the tube. Obviously that's not good. It could potentially dislodge the tube, you know, and then they're in a bad state. So now you want to ask yourself, what do you do to make sure that what you're trying to deliver for this patient, they get it? And on top of that, this patient is not breathing synchronous with the vent. So what you're supplying a patient that may not be getting, because they're supposed to be breathing in synchrony with the vent, because every time they're breathing in synchrony, then the vent gives them oxygen, right? So then, you know, the options are sedate the patient, which I'm thinking very likely is true. Sit next to the patient and tell him everything will be okay. Not really. Increase maintenance fluid. That's not what we're trying to achieve right now. Let the patient extubate himself. We don't want that. So we want to sedate the patient. So why do we need sedation? We need the sedation for anxiety, pain. We need to facilitate mechanical ventilation. We give the sedation for treatment or diagnostic procedures. Also for patients' comfort and control of pain. It reduces incidence of ICU delirium and avoids self-extubation. So critical ill patients experience pain more readily than healthy subjects. Hypernocioception. The most painful experience for ICU patients are endotracheal suctioning and being turned in bed. In addition, 30 to 50% of critical ill patients experience pain while at rest without a noxious stimuli. This type of pain typically involves the back and lower extremities. The heightened pain experienced in critical ill patients is attributed to immobility and a systemic inflammation. The rest pain experienced by ICU patients is similar to the myalgias experienced during a systemic infection. So correctable cause of agitation. So you want to rule out reversible causes that's not missed. So if the patient is agitated, is it because they're not getting good oxygen, hypoxia, or is it because they're retaining CO2, hypercapnia, or is it hypoglycemia, or is it endotracheal tube malpositioning? Is it a pneumothorax? Is it pain? Is it drug withdrawal? And then other reversible causes: full bladder, bed positioning, ventilation flow rates, uremia, disorientation, drug side effects, sleep deprivation, noise. So when a patient is agitated, obviously they can't tolerate they're not tolerating the delivery. So you need to figure out why they're agitated before you try to sedate them. Because if you don't figure out why they're agitated and you sedate them, they can't communicate again. So if there's something other than that that's causing an issue, you need to figure that out so that sedation doesn't mask or obscure that. All right, so this is a score that a RAS score that we use for sedation. All right, sometimes when you sedate a patient, you basically you do this to kind of like give a RAS what you want. So you have all the scores, and so this is something that is used in ICU to put parameters on the sedation. So choices of sedation you can use for the sedatives. You can use amnesia, hypnosis, or anxiolysis, or analgesia. So if you want to treat pain predominantly as a sedative, so if you want to sedate the patient, if you want to take care of their pain as well, so you have to think about the type of sedative that you want to use. So just like the Pressors, everything has reasons why you use it. You don't just use something just for you have to look at what you're trying to treat. So there are some sedatives that also have pain medications with it. And there's some pure sedatives that don't have any pain control with it. And we'll talk about those as well. So you have propofol. So you have opioids that treat pain, but they can also put you to sleep. You have propofol. You have benzodiazepines. You have alpha-2 agonists. And then all of this is for patient comfort. So you have benzos. So benzos, are cover these, but they don't cover analgesia. You have methodomidine that gives you analgesia and anxiolysis. You have haloperidol that treats this part, and then you have opioid analgesia that's strictly for pain, and you have propofol, which doesn't touch any analgesia but helps you achieve this. And then they all have their specific aspects to them that we utilize that is helpful. So opioids. So you have fentanyl, which is an opioid potent analgesic. The onset is within 30 minutes. It peaks at 5 to 15. The duration is 30 to 60 minutes. And so you just titrate accordingly. So these are titratable medications. And if it's predominant pain that's causing this patient to be agitated, you want to give them fentanyl if you know this is pain. Like a lot of ER visits, and I don't know if anyone if you guys are interested in ER, but fentanyl is used a lot because people come in. You need to first treat their pain that just came in a car crash. Fentanyl is good, right? You can sedate them, and then you can not intubate them and treat their pain on top of the other pain meds. But the point is the sedation if you want to do anything for them. If they're very combative and they just went through pain, fentanyl is good. And then you have morphine, right? Morphine is a long onset peak. You want to avoid this in hemodynamic instability, avoid this in renal failure patients. You want to avoid this in hypotension. So you don't really want to give this like that in ICU setting. This is just good for pain with patients that don't have any renal failure. So you can you know, you can give morphine. So adverse effects of, the opioids is respiratory depression. You have hypotension. You have decreased GI motility, pruritus, metabolic accumulation with morphine secondary to RF. So when you're giving a patient opioids, always consider bowel regimen, Colace and Senna. So you always want to give bowel regimen because these decrease GI mobility. A lot of people who are on opioid medication in the hospital, they've become constipated over time. And you ask them, have you had any bowel movement? And they say, no, I have not had. You want to figure out what is causing this. So, so when a patient is on opioids, you want to put them on bowel regimen. So now benzos, talking about benzos, and this is what's happening in the synaptic cleft. All these neurotransmitters are happening. If you guys took molecular biology and all these things, at least the synaptic cleft and all the neurotransmitters, what they do. So benzodiazepines, they bind just like all these other stuff. They bind and they do other different things in the action potential channel. So the benzos we use, we have diazepine, which onset is 2 to 5 minutes, peaks at 5 to 30 minutes, and lasts greater than 20 hours. We have midazolam, and then we have lorazepam. So you use all of these, and they all have their particular side effects and reason why you use. So the benefits of benzos is an anxiolytic, amnestic, and for sedating. The risk that you have with this is delirium. They don't get any analgesia with this. You can get excessive sedation from this, and then you get something called propylene glycol toxicity from lorazepam. So what you want to do is evaluate when a patient has unexplained acidosis, and then particularly problematic in alcoholics due to dosage use. So with alcoholics, alcohol is already a benzo substrate. So they're going to require more. Some of these patients who are already drug users in some sorts or things like that, their requirements is going to be a little bit higher for these medications. So you want to be able to understand that and say, oh, this is not good for an alcoholic patient. I need to give something else, because for them, they're going to be at risk of respiratory failure because you got to use high amounts, and they're going to be hypotension and withdrawal. So for them, you have to use high doses to get what you want. So we're going to skip through this. All right. So case number 4, 24-year-old medical student presents after an altercation in Marina Cafe Tiki Bar, suffered from the closed head injury and was intubated for airway protection with a GCS of 6 with etomidate and succinylcholine. Patient is now agitated and is attempting to pull for his ET tube. What sedation would you choose? So basically,
someone said C. There's people coming in saying C in the chat.
See people saying C. So propofol, 25 milligram push, followed by a drip and restraint.
There's also a couple of A's and B's, but C seems to be the overwhelming response.
Okay. All right. Let's see. So definitely will not be B or D. And then with the morphine, it's a strictly analgesia. With propofol here, because this person has a closed head injury, he might be agitated because of pain. He might be going through pain. And then propofol is just strictly for sedation, right? So let's see. So C is the answer here. So now explains propofol, what it does. So propofol activates the GABA channels. So in short, you know, it opens the chloride channels and causes the chloride to enter. Then this brings cell closer to the reversal potential for chloride, which is below the depolarization threshold. Thus, the membrane comes to be hyperpolarized. So basically, relaxes it because it's hyperpolarized. So it activates GABA channels. It's an amnestic. It's an anxiolytic. It's very rapid. It's very quick. It wears out quickly. You know, you can use this for very combative patients to kind of, if you want to quickly sedate them, such like that patient. So the uses are anticonvulsant. It decreases intracranial pressure. It decreases shivering, easily titratable. So the adverse effects is there's something called green urine is observed occasionally from harmless phenolic metabolites. You can get hypertension, bradycardia, respiratory depression, and things like that. But propofol is very good. So there's a propofol infusion syndrome. It's like an abrupt onset of bradycardic heart failure, lactic acidosis, rhabdomyolysis, acute renal failure. This syndrome almost always occurs during prolonged high dose propofol infusion rates. So you want to be able to kind of be careful with the rate of infusion in short. So next sedative is dexmedetomidine, which we call Pressors. So it's a central alpha 2 agonist. It's a moderate anxiolytic and analgesic, no respiratory depression. So it's not that strong, right? But it's good. It's a good maintenance sedative to have a patient on. Because it's very moderate. You don't want the patients to be snowed out, but you want to have some type of sedation. So this is a good maintenance to have them, especially when they can tolerate. So the disadvantage of this is hypotension and bradycardia. And you could also get withdrawal tachycardia. So some of these sedatives, if it says hypotension, then sometimes you put a patient on pressors to augment their disadvantage, right? But you get what you want out of them, right? So sometimes you put a patient on a sedative, they become hypertensive and bradycardic, and then you put them on a pressure like Levofed, as we spoke, to kind of give them two things that help. So the sedation part is allowing for proper ventilation, the pressures to keep them hemodynamically stable enough to tolerate. So as they're healing, you start weaning the sedation and you start weaning the pressures to get the patient back to normalcy. Because you're doing all these artificial things to achieve the ultimate good oxygenation and to calm the patient down so they could tolerate the management. ICU patients are very combative. They're, on fight or flight mode. They're trying to survive. Whatever the case is, uncomfortable, in pain. It's just unfortunate, but you have to give them these medications so that the ultimate treatment that they need, they're getting. At the same time, you got to consider when you sleep a patient, what is being masked. If they're having pain while they're laying in bed, you got to give them something that has pain relief as well. So that's the whole mindset in a clinical setting. When you see these patients, you have to think about all these things. What are they here for? What do they need? How beneficial is what they get for their overall wellness? So you have neuromuscular blockers as well that you can give a patient to prevent muscle spasm and things like that. And then also to avoid this synchrony. So you could give neuromuscular blockade. So your trachea and all that, just yourself in general, people can be fighting the ventilation and you want to block that. So you can give a paralytics to kind of help get that to increase the oxygen consumption that the patient should be getting, because sometimes that can be counteracting what you're doing. So sometimes then you need to paralyze them. So you have a depolarizing agent, succinylcholine. You guys will learn about this in the future, but this is one of the agents that is used to basically bind acetylcholine receptors, right? So it blocks it, because acetylcholine binds the receptors, it activates the action potential. But by succinylcholine binding and compete with acetylcholine, you don't activate that. So it basically kind of, causes because phase 2. So in the action potential, phase 1 is the depolarization phase, and phase 2 is the then the phase 2 is the depolarizing phase, and the muscle is no longer release acetylcholine to nerve endings to fire. So that's what basically this does. It blocks the phase 2, so that this doesn't happen, and basically you shut down the muscle for a second, however long it lasts in the body. And then you have the long-term non-depolarizing agents. So you have vecuronium, you have pancuronium, you have cistercurium. So like I said, everything has its good and bad. This can cause cardiovascular dysfunction, so you want to be careful. And this is good with normal hepatic and renal function. You can use this one, cistercurium. This can cause hepatic and renal insufficiency, so you want to be mindful. So this was the one that we typically use, but like I said, depending on the patient's situation, these are the ones that you decide to use. So you have to know the patient. So this is a monitoring system. It's called BIS. Basically, it tells you the level of sedation that the patient is in, or level of response they're able to give. So 0 to 30 is deep anesthesia, surgical anesthesia, common is 30 to 50, explicit recall rare 50 to 60, drowsiness and sedation common 60 to 80, wakefulness common 80 to 100. So these are the parameters that you look at that you want. If you want the patient, depending on what level you want the patient, BIS level you want the patient to be in. So for paralytics, you basically do this. You plug this in, and it fires. And if you get 4 beats, if you get fire in 4 beats, the patient is not paralyzed. If it's 3 out of 4, it just tells you level. If it's 0 out of 4, then you're like, okay, this patient is paralyzed. There's no firing. This patient is completely blocked. They don't have acetylcholine release, so nothing is being delivered to the nerve endings. So sometimes the level of how paralyzed you want them to be, you decide based on how much you're going to give them. So that's all, folks, for sedation and pressors.
Thank you so much. This presentation was so much more than we could have asked for. This was awesome. Everyone loved the variety and the connection that they see between their classes they're taking now. So this was so great. Thank you.
And then last but not least, can I talk about COVID just briefly?
Of course, yes.
All right, so what we just talked about right now is very, very important, because it's very, very important because especially in this time period with a lot of COVID, right? We know COVID is a viral respiratory infection that compromises the airway, right? And so basically, it's a droplet. That's why a lot of people have to wear masks and stuff like that. You guys know the gist of COVID by now. But why COVID is so difficult to treat, especially when a patient is already So what gives you the criteria to say this person has severe COVID is the oxygen that they're able to get. When you give a patient a pulsometer, you basically say how much oxygen are they getting, and you want the patient to obviously be in the high 90s. It tells you your saturation and stuff like that. Even if a patient is anemic or something like that, you still want them to have a good saturation because it tells you the availability of oxygen to tissues. But when you start falling into saturation levels of 94% or less, you have to be very worried that this patient's not getting sufficient oxygen. So decreasing saturation is not good because, your brain needs oxygen. The more oxygen you have, the more you can use sugars and stuff like that to go through glycolysis and make ATP, so on and so forth. These things are very, very important. So in hospital setting, and you see a situation like that, patient has COVID, not breathing well, needs supplemental oxygen. Sometimes the level of supplemental oxygen that the patient gets when they come in, if room air is not sufficient enough, you give a patient a nasal cannula, right? Just a nasal cannula tube that pushes oxygen, and you can decide how many liters to kind of give. The difference with the nasal cannula is that it's just there closer to your nose, and then you can kind of like use your own particular effort to, breathe it in. It doesn't have pressure with it. And then next thing, if the nasal cannula is not good, then you kind of put the patient on high flow, which high flow is an advanced nasal cannula, sort of, where there's pressure applied with the amount of oxygen that you give. So you kind of like high flow, it pushes the oxygen into your nose. It can be uncomfortable for some patients. They may not like that and stuff like that because it's so close, and it's like, but obviously the most important thing is to make sure that they achieve oxygenation. If a patient is still not doing well on a high flow, before you do invasive ventilation, such as intubation, you can put them on a non-invasive, right? You put the patient on a non-invasive, whether it's like a mask, there's something called a BiPAP or CPAP. So you can basically regulate their inspiratory pressure and their expiratory pressure. So in driving oxygen, you need pressure. So sometimes by regulating the pressure, you help drive that oxygen that you want. Because what happens with patients with lung disease or things like that is that it affects the pressure in that system. So oxygen delivery is not getting there. So they have a ventilation issue. So with this, you try to help at the meanwhile while the patient is getting treatment. So parts of managing COVID is, if they're in a hypoxic state, you have to supply oxygen. But on top of that, you have to treat the COVID, period. Right? So when we treating COVID, most of the time when a patient comes in, and that's why it's important in clinical medicine to ask the right questions. So you want to ask the question, so important thing is, what symptoms are you having? So that's a question you want to ask. What symptoms are you having? They'll list the symptoms. And then that's when you start having differentials in your mind, right? So what symptoms are you having? When did the symptoms start? That's an important question. When did it start? Because in medicine, you need to formulate a timeline. Like, you never be accurate, but the closer you get from obtaining information, the more accurate you can get. The goal is to get as accurate as possible in making a diagnosis. But these here increase your accuracy by you getting the right question. Were you around any sick contacts? Oh, yeah, I was around somebody who recently got tested positive. Okay, cool. Somebody was recently positive. So likelihood of you getting it is higher now because I know that information. So essentially, these are the pivotal questions that you ask, and that kind of like lets you know, okay, this person is COVID-y. And then you want to get a chest x-ray, obviously, so you can look at the heart. I mean, look at the lungs. And you look at the lungs, and then you check your inflammatory markers and stuff like that. So what you do is you order CBC, right, which tells you what the constituents in the blood, and then you order BNP, which is basal metabolite, and you can look at that and you see what's going on, because sometimes it could also tell you infection processes. Some bacterial infections or pneumonias can cause drop in sodium levels or this and that. So you want to get all of this, and then you want to, there's something called a D-dimer. These are markers that you order to see, because they go very high when you have COVID. Then you have ferritin, which is another inflammatory marker that you order. It tells you something, regarding inflammatory response as well. And then if you're thinking bacterial infection, there's a marker that we use called procalcitonin, which is another inflammatory, which is released when it's very high, when it's bacterial infection. So in the interim, you order these things, and then of course take the COVID swab, do the COVID test, and then you want to do that. And then there's many cases when a patient that comes in with high suspicion of COVID, you do a swab, and the swab is negative. Because of a negative swab does not always mean, you don't have COVID. If the clinical picture is very clear, because when the CBC comes out and you look at the white blood cell count, what the thing about COVID is that in infectious states, you expect the white blood cells to be high, right? And then you expect on a viral infection, you expect that the lymphocytes, which is that fight viral infections, you expect them to be high because they're trying to mount a response. But then with COVID is that you use up a lot of lymphocytes, so you end up seeing a low level of lymphocytes. So that's indicative, like, okay, this is COVID, because the lymphocytes are low. Because it's low does not mean that they're not. It means that they're overusing themselves. So that's why it's low. And then this picture right now alone, says, okay, I'm suspecting COVID. Now the question is, when do you start treatment? So the phases of the phase of the viruses, you have the replicative phase, you have the inflammatory phase. So it's important to note, depending on the days, if the patient was recently exposed, and then you can be like, oh, they're still in the less than 10 days window since their onset. You can say this patient is still in the replicative phase. And in the replicative phase, you want to treat the virus. You're not really treating you want to fight the virus, so you're not really treating symptoms per se. You fight the virus, and in order to fight the virus, you have to give an antiviral. So there's a broad spectrum antiviral that we've been using in the hospital called remdesivir. So you want to fight the virus in the replicative phase, because you don't want them to replicate to amount that is a lot. So you want to reduce the viral load, right? Because it takes a while for your body to kind of start responding to the attack. Because when a virus comes into your body, they hide very well for days, right? You're not getting any symptoms; they just hide. The only time that they set off your alarm system is when they try to escape. So they're already in the machine. They already did what they wanted to do. Now, when they're leaving, sometimes they try to leave quietly, but in leaving, they set off an alarm, and your body says, you know what, there's something here. Your body starts to relieve inflammatory, messengers and stuff like that. That's how you get your fevers, how you get your myalgia. That's how you get all of that, because your body is fighting. It's not the virus that's giving you these symptoms. It's your body ability to fight that ticks off these things. And the experiences that you have are because of the fight. I believe, I don't know exactly why people get loss of taste, loss of smell. It has something to do with the virus itself and where it attacks. So your body attacks those at those places, and hence why people can lose their sense of taste and stuff like that. So that's what you do. You would give antiviral medication, and also at that time, we could use something called convalescent plasma. Plasma obtained from somebody who was recently COVID. They have antibodies in their plasma. That can donate this, and you could utilize this. It should, the plan here is that it should help in that replicated phase. And so now, when you're in the inflammatory phase, this is when you do the steroid treatment, right? You do the steroid treatment, there's another medication that is utilized in this inflammatory phase called tocilizumab, right? In short, toci. So if you guys have ever taken immunology and you learn about inflammatory process, we go through inflammatory process all the time, right? You get bruised, you have releases here, or whatever the case may be. You go through inflammation, but inflammation, it's not good after a couple of days that you've been in an inflammatory phase. Like you can have an onslaught to the lungs. And the problem with the COVID is that the inflammation process for some people may be so long because it's in the lungs and it's still being fought. Like it's still surviving in the lungs and it's being fought. And then you end up having fibrosis. You have a damage to the lung. You have acute respiratory distress syndrome, ARDS, and then prolonged state could cause fibrosis. And fibrosis further injures the lung parenchyma, and you're not able to get good diffusion of oxygen. One thing is ventilation, and the next thing is the diffusion aspect. So it's important with fibrosis, you can't diffuse it doesn't diffuse properly. So regardless if you're given good ventilation support, but if fibrosed lung is just a very tough lung. So this is how we try to manage it, and then ultimately, you don't want to start the steroid treatment too early because it can also not be good for the lung. But when there's an inflammatory state going on, you want to do the steroid treatment. So you typically do a steroid treatment for 14 days. And so when a patient requires to be intubated, you're saying that they're in a severe COVID case because their oxygen saturation is low. So when you intubate these patients, now depending on the patient's underlying comorbidities, you may have other things that you need to also manage. So remember, we said when you intubate a patient, you have to now sedate them, and they may require pressors because they may be in septic shock as well. So now you have to apply that aspect of ICU management in these situations. And this is what we have been seeing that kind of compromises, the resurrection for a lot of these patients coming out once they get intubated, because some of these sedatives and pressors, that require so much of them, and then on top of that, they have like kidney issues. You want to monitor their cardiac output. They're hooked up on so many different lines while in the hospital that can be at risk for infection, and you continuously want their lungs to improve. And prolonged ventilation causes laryngeal edema. Prolonged intubation can cause, or oxygen supply can cause barotrauma to the lungs and stuff like that, especially the ones that are requiring high amounts of ventilation support, right? So it's a tough time that we're dealing with, especially in this particular severe thing, and then they end up in ICU, and these are the management. Most of the time, these things are supposed to work. That simple calculation with MAP equals cardiac output, stroke volume is simple calculation. Use these parameters and you try to apply all of these things to maintain, but there are times these things fail. What you're fighting becomes a little too powerful, and on top of that, the patient's state is not helpful either. Their age, their level of obesity, there's so many things that could count around what we do. And that's why a lot of these people, when they have these situations, they don't do well. And that's the general gist of why a lot of people are dying as a result of COVID. You know, because when they get into this state and you try to your best to help them remain hemodynamic stable till they get out the inflammatory phase that they're stay in, and to combat any damages that has been done because as a result of such stage, it gets very tricky and tough. So ultimately, some people will be on the ventilation for a long period of time, and then they do well, but they've been on ventilation for so long that they've developed weakness to breathe on their own. So you basically do a trach, you know, you do a tracheostomy, and then you do a percutaneous esophageal gastrotomy, you know, to basically give a tube straight to the stomach for them to eat. So, and then those people that survive, they get the trach, they do well, hopefully. And then at some point, you know, they'll close the trach and they'll be able to breathe. But a lot of people don't do well, and people are dying. So, anyway, that was a short overview of COVID management. I don't know how much any of this particularly stuck with you guys, but I hope I gave you guys a load. I hope I kind of put you into the ICU world if you were shadowing what you see. It would have been better to like have monitors or virtual bedside and stuff like that. Be like, oh, in this case, this is what you do, but you know, this is the best we can get. The point of this is that, you know, at least one day, even if you rotate in a hospital and you get a chance, at least this right here can reinforce some of the things you learned on that moment. Just kind of, it's a continuous learning. This is a continuous, like this that I just talked about. I personally, if I don't pay attention to, I may forget it. So a lot of doctors and things like that, you have to continuously revise. It's just like a jump shot. If you don't shoot the basketball often, and one particular year you were a great shooter, but then you stop shooting, you're not going to remain a great shooter. You know, you have to keep shooting. You can see yourself come in and you just be rusty. You have to keep shooting. You have to warm it up. So every now and then you have to warm up what you know, and you know, stay humble, you know, about it. Always be willing to learn because medicine is always changing. If you assume that you know everything, you don't know everything. You know, you're gonna see some patients realize that you don't know anything. So sometimes it's really a shit show, you know. But it's an intellectual shit show in a way where okay, you're trying what you know, but dang, what else? All right, cool. You call somebody else that may have any insight what to do, and then we all do it. And then if patients improve, then you're like, okay, cool. I learned this. Next time I see a situation such like this, I will apply this, you know, kind of reasoning and see if that gives me a leg up. If it doesn't, then you try something else. And then, you know, medicine equips you to be able to do all you can. So, well, I hope you guys, you know, in the future, I'll be open to doing another one of these. You know, and this was exciting. Any questions?
Thank you so much. We would love to have you back. This was such an informative session.
Yeah, there's tons of people that were saying that they just got to put together a lot of things that they've learned in their anatomy and physiology classes and, you know, other courses. So it's cool to finally see it in action.
Good. I'm glad.
We'll get through some questions. I think one of the more recent questions someone had was about like sense of smell and sense of taste with COVID.
Mm-hmm.
Like, does that come back? Does that happen in everyone? If you could kind of talk about that, I think there was like a little bit of confusion about how that works.
Yeah, I've heard. I haven't. There's no true study. I just know that people get it back shortly. Some people it takes a while. I don't have the right particular answer for the return of that. You know, I guess it's just a gradual process and individual independent. Just since the fact that there's so many variations to the timetable, one can't quite actually be perfect in saying, oh, this will come back after 10 days after the infection subsides. I know some people, it takes a while. And then when you hear the story, you're like, oh, for real? And some people tell you, I never had the loss of smell. And I'm like, okay, cool. And then the ones that do, that you ask them, has it returned? They'll say, oh, slightly, but not really there. So I don't know if it's psychological for some or, and here and there, but nobody quite knows. But as long as you're not in a severe COVID state, you should just be patient till it returns. You might avoid smelling your food for a change.
Kind of going off of that, another COVID question that someone had was, when do you know when the right time to start steroid treatment for COVID is? Is it depending on when their pulse ox at a certain time?
Yeah. Yeah. So a lot of times you start steroid if a patient comes in and they need oxygen support, you start steroids. It's supposed to, help during that time period.
Great, thanks. I think we definitely had a lot of questions asking about your medical journey, but I think that might be, something that we can save for next time. So I guess we'll just end it on a note of, as on the topic of COVID, we're ending or getting vaccinated and rolling that out and hopefully ending it soon. Do you have any last piece of advice for us as pre-med students just managing this very weird time?
So in the pre-med position, there's just so many things that you have to arm yourself with, especially when going to medical school. I think what should be the primary focus is knowing what is required of you, right? Such as the MCAT and all this stuff that shadowing, research, exposure. I think one of the most important things I said, don't do, have the desire to be here, but don't rush the journey. I know a lot of times you be itching and scratching like, damn, I want to start this, I want to start that. You want to be sure when you start it, and on top of that, don't be lazy. Don't assume that, okay, you take care of this tomorrow or you send this email tomorrow. If you have any mentors that you could get a leg up, get in the habit of communicating with your mentor, on a weekly basis, and stuff like that. So you could be on par. People love to see who's hungry and versus who's just, talking the talk, So of course, people are very busy and it's very difficult. It's a difficult place to be. Whether you're pre-med, whether you're a med student, whether you're a resident, when you're still reaching till you land as an attendant or you're practicing and you have your clinic or working in a hospital of your dream, or, you always working, you always grinding, so you have to really, really not waver. You're gonna have depressing days. You have a lot of those days. You have days where you think you're not good enough. You're gonna have many of those days, but you have to surround yourself with people who are as passionate as you in this journey. And know that there's enough room for everybody. You can't look around, you're like, damn, all these people want to go to medical school, I'm competing with them. No, you're not competing with them. You compete with yourself. Because at the end of the day, you decide the choices you made. I made the choice to go to Caribbean school after I've already taken the MCAT 4 times and applied 4 times at the time, and applied 2 cycles. So 2 cycles. Each time I applied twice in a cycle. Each time I took the exam twice in a cycle, I meant. So I applied 2 cycles and, it didn't work out. So I opened my mindset up to go to Caribbean school. I know some people say, oh, I hear this and hear that about Caribbean schools, but you don't know what you don't know. You just hearing what you hear, and people go to Caribbean schools that do very well, and they get great residencies and specialties and stuff like that. But it was their decision to define the odds, right? But if you go there with the mentality of like, oh, I don't know, you know, this is I'm bigger than this, and da da da, it will kick your butt, and next thing you know, you coming back home because you didn't make it, because it's just tougher, you know, out there. So you have to be very open-minded. If you know your ultimate goal is to get a particular medical school here, you have to do what you need to do. You have to be competent. You have to work. You have to get a good MCAT score. You know, and if you have a decent MCAT scores, you have to be like, you know, you have to work viciously in other aspects that could make you stand out. If your communication is where you're really good at, start opening up dialogues with administrative people in these fields and emailing them and say, hey, I'm an aspiring medical student, you know, and this is what I have so far in my CV. What do you think? How can I improve so I can be a better applicant for next year? Maybe they respond, maybe they don't. But when you're doing things like that, you're gonna get some type of response. They're gonna be like, this person's proactive. This person, you're trying to fill the shoes so you actually know what they're looking for. Because if you don't know what they're looking for, you apply blindly, then you wouldn't know where you miss. Because if you know where you're shooting at least you know when you miss, right? You can't shoot, you know, blindfolded. The only people that shoot blindfolded are people that actually know the gym that well and they know where they're shooting at, right? If you don't know your place that well, you don't know where you're shooting at, even if you're blindfolded. Even if the level of difficulty is increased, at least you know where you're trying to shoot at. But if you don't know, it's even more difficult, right? So you have to be, that's one thing I say, know what is required of you, and you know, move accordingly.
Thank you so much. That was so such invaluable advice. So we appreciate it so much for giving us your time this morning. We definitely look forward to having you back on to talk about some more interesting topics. We hope you have a great rest of your day, a great weekend, and we'll see you soon.
All right, see you guys.